Ó, que tô comendo uns pistache apimentado aqui, rapaz.
Professor Veiga, boa noite.
Tá sem microfone, professor.
Não estamos ouvindo o senhor,
Alô,
professor
alô,
Veiga.
hello, alô, hello. Tudo bem aí, pessoal?
Boa noite, professor.
Boa noite, estão me ouvindo?
Agora nós estamos
sim,
ouvindo
professor.
bem.
Boa noite.
Tá bom.
Nós estamos que nem Mano Menezes para Filipão já. Fala muito, fala muito.
Dr. Jean, saudações
Professor.
santistas.
Ganhou do Corinthians?
Ganhou de 1-0 ontem.
É tão raro isso acontecer, né?
Mas vocês estão
tem que
uma
fazer
ficar
uma
de fora da
gozação, né?
Libertadores.
Ô, Paulinho, ó, e o Jean faz de conta que não sabia.
Olha,
Tudo bem aí?
Mas amanhã tem São Paulo e Palmeiras, hein?
se começar a falar muito, eu vou torcer pro Flamengo, hein, cara?
Foi só a Aziz entrar para a gente falar de São Paulo e Palmeiras amanhã. O quarto lugar no Mundial vai querer jogar com o Tri Mundial. Ele está se fazendo que não funciona lá. Não funciona, não estou escutando.
Boa noite.
Fala, Marcinho.
Tudo bem, Márcio?
Tudo bem, Filipão? Paulo, Jean,
Então,
Veiga.
Márcio Rassi,
Olá.
o homem que mais trabalha no C. Camargo.
Desculpe se eu não falei o nome de todo mundo, é que eu estou encantado com os óculos novos do Paulo.
São bem discretos, né?
Cara, isso eu nem comento, né?
Hello, everybody.
Hello, everybody.
Como a gente vai falar em inglês...
Saudações do... Como é que é o nome do time mesmo? Al-Hassan?
Como a gente vai falar em inglês hoje à noite, é Good evening, Professor Aziz.
Hey, Aziz. Salvação do Al-Hassan. O melhor time egípcio de todos os tempos.
O time do Paulo, mesmo quando está na liderança, não consegue ganhar nada. Aí ele começa a encher de saco de todo mundo, né?
Estou lhe ouvindo mal, Jean. Seu microfone está baixo.
Eu vou aumentar aqui.
Mas isso aí, acho que viajar para o outro lado do mundo e conseguir o quarto lugar sempre é uma vitória.
Também acho, velho.
Até a câmera do Aziz está balançando. Tá?
Ô, Paulo, pelo menos não foi como a nossa com o Mazembe, que ainda a gente pagou em prestações, que tinha torcida, né? Foi aquela humilhação e ainda teve que ficar pagando mais 12 prestações, 11 prestações.
Puta, você sabe que eu nunca fui lá ver uma final de Mundial, mas toda vez que o São Paulo chegou lá, ele levou, né, cara? E o Inter leva esse campeonato? Se parar de brincar, né? Porque tá dando umas brincadas também, né?
Na verdade não é brincar, Paulo, que o time é muito ruim, deu uma sorte desgraçada ali naquela sequência, mas agora começou a cair na realidade. Agora, o problema é domingo jogar com dois adversários, a arbitragem e o Flamengo, né? É mais difícil.
Hi, Kate. Hi, Kate. How are you?
Good. How is everything?
Thank you for coming.
Thank you. How's São Paulo?
I think no one wants to answer that.
Much
I can
COVID?
tell you how is Campo Grande. Campo Grande is terrible, man. But São Paulo was a little better now, no? No?
You mean about the weather?
No, about the infection.
There's a virus. Did you hear about this virus, Sean?
Influenza.
I got the second shot yesterday, so I feel better now.
Forgotten now.
The vaccine,
No.
the corona vaccine, coronavac. For a Chinese virus, you have to have a Chinese vaccine.
Which vaccine did you get?
Coronavac.
I took the Chinese too, you know? Even because the needle is very short.
We have Pfizer and Moderna here.
Yeah, you're getting the Moderna, right?
Yeah, Moderna. I got Pfizer.
You got Pfizer.
Mm-hmm.
Did you get any reactions?
I got terrible night sweats the first day. I thought I wet the bed. I was drenched head to toe.
So now
I took the Oxford one.
Fala, Antônio.
Oxford too.
Fala, Antônio.
Professor Abessa.
Antônio.
Aurora Boreal, olha lá. Ô,
Antônio.
guru aqui.
O Rio de Janeiro agora tem a Aurora Boreal.
The virus really came to change the world. Now Rio de Janeiro has a Aurora Boreal.
Olá. ¿Cómo está
Pablito.
flaco ese Pablo?
Pablito.
Pablito, está muy flaco.
Pablo.
Turn on your microphone.
Estoy muy flaco. River me hace perder peso.
Sí, percebe-se, nota-se.
¿Cómo andamos? Tanto tiempo.
Sí, mucho.
Tenemos que hacer una reunión ahora cuando...
Professor Guinto.
Olá. Aqui estamos. Você está sendo cercado pelo torreno. Tome cuidado.
Hola, doctor Guinto. Buenas noches.
Buenas noches, ¿cómo están? ¿Todo bien?
Tranquilo.
Aquí estamos listos. Buenas noches a todos.
Buenas noches.
¿Cómo está?
Buenas noches, buenas noches.
Yes, sir.
Dr. Borba, faltam 2 minutos para iniciar. O senhor pode começar a transmissão.
Não, só um pouquinho que eu estou com um problema na conexão aqui, eu já estou resolvendo isso aqui. O Dr. Al-Mefty não está conseguindo entrar.
Perfeito.
Ele não sabe mexer no computador. Me manda aí do Soriano dele.
Pedro, Dr. Al-Mefty just called me that he cannot get a link that works.
Fala em português com ele, rapaz?
Pedro.
Vamos reenviar,
doutor. Esses óculos bacanas aí, tu quer falar inglês? Eita.
Você mandou um novo para ele?
O Paulo
enviando agora, doutor. Estamos enviando agora.
Esses óculos aí, o cara... Ei, Carlinhos, com esses óculos aí, enlouqueceu de ver.
O cara tá, ó, tá
Hi,
fecho.
Carlos.
Hi, guys.
Just one second. Dr. Soriano and Dr. Al-Mefty is trying to come in. Just one second, we can start, okay? Ó, a lot of people, assim, várias pessoas estão com problema para entrar na reunião. Pedro, recebi outro e-mail aqui, tal de o pessoal de Marília não está conseguindo entrar aqui na reunião também. Alguma coisa está acontecendo no link.
Vamos checar, doutor. Só um momento.
Pedro está com uma voz diferente, né, cara?
Esse não é o Pedro.
Esse aqui, não.
Oh, there he is.
Hello, Professor Al-Mefty.
Hello, everybody. Finally got you.
The first way to connect,
Hello,
Professor,
Professor.
is
Where's
turn
our
on the
speaker
micro,
for the night?
the computer. See?
I don't hear you, Barbara.
Oh, Dr. Braga is here. Where is Dr. Braga?
Are you mute, Borba?
No.
You cannot mute.
Your hero device.
That's an impossible task to mute Borba.
Hello, Felipe, saludos.
Hola, doctor Soriano.
Saludos.
Buenas noches.
Saludos, señor.
Hola, hola. Hola.
Professor Braga.
Doutor Braga.
Doutor Braga. Ligue aí seu microfone, professor.
Yes, I'm here.
Yes.
And, this chap that is son of great Al-Mefty, isn't it?
Braga.
The son of Al-Mefty.
Hello, Fernando. How are you?
Oh, man.
It's so good to see you.
Yes, thank you very much for me.
Yeah.
It's a pleasure.
Dr. Soriano is online? Onde está você, Antônio?
Borba, ele tá dentro, mas a câmera dele congelou. Eu acho que ele deve estar com problema na conexão.
A minha câmera? Ah, o Mefty.
Não, doutor Soriano.
Ah, Floriano.
Ele entrou pelo celular, acredito.
I see Aldo on the line. Tell him there is no Indonesian for acoustic.
Hello.
But you should try, Dr. Mefty.
Don't give him ideas, Professor.
Yeah.
This guy can go anywhere with endoscope.
Me ajuda aí a
Hola,
procurar.
aquí estoy. Te estoy viendo, Borba.
Okay, great. Eight oh two. Okay, Dr. Jean está aí? Já está aí?
Yo los estoy viendo perfecto, ¿eh?
Usted consegue hablar bien, bien, ¿no? Sí. Perfecto. Okay. Dr. Eisenberg is here. That's fine.
I am here. Hello, everybody. Hello, Professor.
Hello, Mark.
You are live on YouTube also? Good. Now, today I'm the host, no? I control the camera also. Yeah. Now my new hair, see, look at this. And Paulo Cade, you know the situation, Dr. Mefty. Look at this guy. Oh my God.
Now I'm more serious. I have new glasses.
New glasses. Oh my God. Okay. Can you start recording?
Estamos prontos, doutor. Pode iniciar.
Okay. Good evening, everyone. It's a great pleasure and honor to come back again to the webinar, to the line, with all the great people around the world. On behalf of our Al-Mefty Friends and Fellows Association, FLANC, and Neurosurgical Society of São Paulo, in support of Neurosurgical TV, we will start this series, the Dr. Al-Mefty Neurosurgical series. The idea of this series is to discuss neurosurgery, not discuss skull base, not discuss spine, not discuss any topic. We are neurosurgeons. You have so many topics you need to discuss. And the neurosurgeon these days is changing too much. And it's a great honor to me to be here with all the friends in front of our great mentor, Professor Osama Al-Mefty. Today is a very difficult day to the Brazilian Neurosurgical Society, to São Paulo Society, to the Latin America Federation, and for the whole neurosurgeon in the world. Today is the 7th day that our great mentor and professor from Brazil, Evandro de Oliveira, passed away. He's teaching during many, many years. He was the professor of all of us. He changed the history of our neurosurgical society. He changed the history of my generation. And he still will change the history of many generations. I will ask of us, I ask to all of you, 1 minute of silence in honor of our great mentor, Dr. Evandro de Oliveira. Okay, everyone. Thank you, the support, or almost 200 people in February. In the same week of Carnival in Brazil, Dr. Al-Mefty. See, last week supposed to be Carnival. And today it was 2 days after Carnival. You're never working this week. Now the COVID make us work in these days. And I give the word to Professor José Carlos Veiga, President of SONESP, to say some words, and after our Professor José Antonio Soriano, President of the Latin America Federation of Neurological Societies. Go ahead, Dr. Veiga. Thank you very much for all the support.
Okay, thank you, Borba. Welcome, everyone. On behalf of the Association of Neurosurgeons in the state of São Paulo, SONESP, it is a great honor for us to participate in our Al-Mefty series, sponsored mainly by Al-Mefty's fellows and friends, with support of the FLANC and SONESP. We start Al-Mefty series. It couldn't be better start than with his son, Kate. So it's a pleasure to be here. So go on, Borba, with Professor Soriano, please.
Dr. Soriano was online. José, ¿dónde andas? Turn on your microphone. Hello?
My microphone is open. It's
Oh,
okay?
Go ahead. Go ahead, please. Go ahead, please. Now can
Could you hear me, Borba?
Yes, yes, I can hear you.
Borba, could you hear me?
Yeah, I can hear you, but
Hello.
the signal is not so good.
Could you hear me?
Yes, yes.
Borba.
Yes, yes, I can.
Okay, thank you. Thank you so much. I'm so sorry. I'm so sorry. First of all, on behalf of the Latin American Federation of Neurosurgical Society, from all of you, to this series of conference. Not good?
Good, good. Go ahead.
Could you hear me now?
Yes, yes.
Now, it's better?
It's okay.
Better, Borba?
Yes, you can hear. Good.
Hello, Borba.
Yes, go ahead, go ahead.
Societies plan this series of conferences called Al-Mefty. The title, recognition to one of the historically greatest neurosurgeons around the world, Professor Al-Mefty, who has been example to follow and has had the initiative and the leadership to conjoin a world-class group of neurosurgeons from different parts of the planet to share their outstanding acknowledgement in this scientific program that includes select topics that every neurosurgeon should know. Congratulations to all the organizing committee by the great effort and our deepest thanks to all faculties and panelists. Professor Al work with thanks forever to great thanks again. And I'm giving the floor to everybody. Go ahead, please.
Thank you very much, sir. Thank you.
Thank you. Thank you, Luis.
Okay, thank you, thank you. Okay. Some years ago, you talk about vestibular schwannoma. There are no controversy. What's the controversy? Take the tumor out. Sometimes to save the life, sometimes to save the facial, and somebody talk about save the hearing. Today, understand the pathology that you have more and more options. And today, any kind of treatment can be controversy. It's a great honor to us to introduce Dr. Kate Al-Mefty. Kate is training in Barrow Neurological Institute. Kate now is the chief of division of skull base in the Barrow Neurological Institute, one of the largest institutes in the world. And like everybody, Dr. Al-Mefty, the sun is coming. Sometimes better. Kate, thank you very, very much. Go ahead, please.
Thank you, Professor, and thank you to all the organizers for including me in this. Professor Borba tasked me with vestibular schwannomas, where we are and where we will go as a part of the series, and he asked that I do it in the spirit of my father. And when I think of the spirit of my father, I think of this. This is the devil's advocate, which is an official position in the Catholic Church up until Pope John Paul, who had the burden of fighting against the sainthood of any particular proposed saint. And so he would argue that their miracles weren't authentic and even question their motives. And the purpose of it was that the argument should be made, regardless of even seemingly how offensive, how curious it may be. And this was the philosophy I was brought up in. No dinner in my home was without a thought that wasn't challenged. And this carried on into my life. And as you can see, there are always two laughing and one offended party in every conversation, because the advocate will challenge your thoughts. And so in that spirit, I've tried to train my daughter to play the devil's advocate, even to the dismay of her grandfather, and that whatever our conceptions are of something, we should challenge them. Now, we can't know where we are without knowing where we came from. And acoustic neuromas were once upon a time a universally fatal disease when they were diagnosed. In 1822, Wishart described a young woman that slowly became deaf, blind, and subsequently died from tumors on the bilateral 7th cranial nerve pair. Cuvier described a case in 1835 of a young woman who became progressively disabled and ultimately died of hydrocephalus. And progressively, the diagnosis of this tumor and its disabilities that it caused were identified. Early surgical attempts were fraught with deaths, with even Krauss in 1912 having 26 deaths of the 31 cases that he attempted. In 1917, Cushing published his Tumors of the Nervus Acousticus and the Syndrome of the CP angle, where he described the diagnosis of the disease, the gross pathology, the microscopic pathology, the syndrome of hydrocephalus from an obstructed fourth ventricle and the CP angle, and even the diagnosis with a roentogram showing a dilated internal auditory canal, as marked here with the star. He described the surgical technique of a suboccipital craniotomy with ventricular drainage and exploration of and enucleation of the tumor. He was an advocate for not pursuing the entirety of the tumor, and he suffered the results of facial nerve palsies despite that. He improved the mortality rate, the operative mortality rate, to a mere 15%, but the mortality rate at 5 years was 54% due to recurrence. And this shows that just the size of these tumors were diagnosed and the condition the patients were in. Dandy was dissatisfied with Cushing's results and argued for total resection. And the controversies of acoustic neuroma began as early as Dandy and Cushing. Dandy's series, he also improved the mortality rate to 10% in his 45 case series. Shortly after that, people began to argue for the conservative management, arguing that these tumors, if discovered too soon, the patient would suffer more from the treatment than from the disease. And this is Kareens and Pennybacker in 1950 first making this argument. Surgical technique advanced through the 1950s and 60s with advancements by the House Institute, Sammy, Malice, and Yazergil, and many others. And much credit goes to the otologist and the House Institute in particular. This is their publication that was the Journals of Otolaryngology dedicated an entire issue to the House's experience, actually 2 issues with acoustic neuromas, describing their diagnosis, their anesthesia, the facial nerve, hearing outcomes, and houses personal surgical series. And I highlight in this surgical series case number 46, which was the case of a 60-year-old woman that was treated with a middle fossa craniotomy, in which a gross total resection was achieved and hearing was preserved and the facial nerve was preserved. So here we are in 1964, and the holy grail of acoustic neuroma treatment was achieved for the first reported time. So times were good for the surgeons then, and the first major disruption to the field came from the machine of Lexell. Lexell described in 1971 the treatment of an acoustic neuroma with the Gamma knife. Subsequently, next major development was the ubiquitous placement of MRI scans. So this is just a chart from 2000 to 2016 showing the increased usage of the MRI scanner. And 1990 to 2000 has even more dramatic rise. With that, many incidental findings on MRI scan began, and vestibular schwannoma were identified four times in 2000 MRI scans as an incidental finding. And the annual incidence, because of this, began to rise of acoustic neuroma. And not just the incidence, but the size at the time of diagnosis, the patient's hearing status at the time of diagnosis. Sorry. And we began to face a very diverse presentation of a singular disease. So these were at one point the 5 most recent acoustic neuromas that I had seen. And we then had a circumstance in which we all know what to do with this tumor, right? This is the same tumor that Cushing faced. But what do we do with this tumor? And what do we do with this patient with this tumor? Because maybe you don't want to operate on that. Maybe you don't want to radiate that. And so the advocacy for conservative management of acoustics had a resurgence. And this is an early article by O'Connor et al. Describing that. And so now we find ourselves in a place that we have 3 tools. We have numerous anatomical considerations in which these may present. And we have a variety of different clinical presentations, whether we consider the patient's age or medical circumstance, appreciate the patient's hearing status, and other disabilities that the patient may have. Leaving us with 3 options. And I want to just step through each of those options and go through the major studies on that. The first of which is observation, in defining the goal of observation, which is to avoid the risk and the cost of treatment. And for that strategy, we need to understand the rate of tumor growth, whether it's safe to observe the tumors, the frequency of the tumor growth, and what's the consequence of delaying a patient's treatment. Well, these tumors actually grow in a lot of variety of manners. So some may shrink, about, depending on the series, somewhere between 2 and 10% of tumors actually shrink over time. About 35% in this series demonstrated no growth. And then in this just 31-month follow-up, we saw tumors that grew less than 2 millimeters and even tumors that grew more than 5 millimeters. And so not just different frequencies of growth, but different patterns of growth. If we look at the frequency of growth in conservative management, we see a general trend that about in a 5-year period, about 60 to 75% of tumors won't grow. And about 7 to 25% of tumors will require an intervention, meaning that Despite having a small amount of growth, that's forgiven, and the patient continues with observation. We know that intrameatal tumors are less likely to require intervention. We know that we think that tumors that have been stable for more than 5 years are less likely to grow. But all of these studies are somewhat limited in their follow-up. The two of those best studies is one from Toronto that followed 72 patients with a median follow-up of 10 years. 35% of those patients in that study failed conservative management. And about half of those failed in the first 5 years. The median time to failure was about 37 months, and they had a remarkable 22% of tumors that decreased in size. That's a little inconsistent with much of the other series. The next is the Denmark data. Has done a wonderful job of reporting on the conservative management. Here they're reporting on 150 patients with about 10 years of follow-up. 37% had growth, and conservative management failed in 15% over that time. Importantly, 52% of the patients started with good hearing and 22% ended with good hearing. Or in other words, about 60% of those patients lost it, which brings us to the consequences of failure. And really, the primary consequence of failure is loss of hearing. The other symptoms and the effect on other treatments seems to be minimal. And so if we look at hearing during conservative management, about a quarter of patients will have hearing loss in the very first year. So even if you encounter that patient and decide to follow the tumor for the time being, about a quarter of those patients will lose a window for hearing preservation. And that hearing continues to decline over time, and that can occur even in the absence of tumor growth. And here's some more data showing similar results of patients with their hearing outcomes over time. And generally speaking, it is consistent through multiple studies that about 2/3 of patients with good hearing will maintain that for their first 4 or 5 years, and that'll drop off by another half in the coming 4 or 5 years. The smaller the tumor, the more likely you are to maintain hearing, and the better the hearing is at presentation, the more likely it is to maintain good hearing. So somebody with 100% speech discrimination score is much more likely to maintain good hearing than somebody with a 80% speech discrimination score. That brings us to radiosurgery. The goal of radiosurgery is to control tumor growth and preserve neurologic function. Long-term tumor control, 10-year data has repeatedly demonstrated a control rate of between 90 and 98% for avoiding other treatments, and probably about 85 to 90% in tumor growth. Facial nerve preservation, particularly when treated with less than 13 gray, is very good, with about a 1.5% rate of facial neuropathy following radiosurgery. Younger patients and smaller tumors have improved rates of facial outcomes. Initially heralded as a treatment to preserve hearing, and is effective in preserving hearing in the short term, with about 75% of patients maintaining good functional hearing at 4 years when treated with a dose of less than 13 gray. at the tumor margin. And this has been demonstrated in numerous studies, and also demonstrated that lower cochlear doses have improved that. In like observation, the improved pre-treatment hearing status seems to matter a lot in the outcome. However, it is also demonstrated that progressive hearing loss is expected. In most studies with good hearing data at 10 years seem to demonstrate that only about 25% or less maintain good hearing 10 years following treatment. I just add this in. This is probably the most recent study, just published in February, of 200 patients treated with a margin dose 12.5 gray. And serviceable hearing preservation rates were about 27% at 10 years. Tumor control was 90%, treatment-free at 98%, and 1.5% facial neuropathy. So both the observational studies and the radiosurgery studies have a high rate of consistency between them, meaning regardless of the center that's reporting the data, the numbers seem to consistently fall in a similar range. One caveat that is ought to be made about the radiosurgical control of tumors is that it ought to take into consideration the likelihood of tumor growth. And so this is essentially a mathematical study in which they take into consideration what's really the tumor control rate if we're assuming about 2/3 of these tumors aren't going to grow anyways. In radiosurgery, in that circumstance, they estimated is effective in about 80%. It brings us to microsurgery. The goal of microsurgery is what it was 60 years ago, and that's to achieve a tumor cure and preserve neurological function. One distinction is published results are highly variable and seem to be surgeon dependent. Gross total resection through these studies is in the 90 to 100% range for these small and medium tumors, with a risk of recurrence at about 3%. If we look at hearing preservation surgery in skilled hands, we see that hearing can be preserved in somewhere between 50 and 75%, with good facial nerve outcomes in about 95%. And that seems to be consistent in the modern era, that facial nerve outcomes, a good facial nerve outcome being House-Brackman 1 or 2, is achieved in 95% of vestibular schwannomas when they're of a small and medium size. Long-term hearing preservation with surgery, as a distinction to radiation and observation, is typically durable. Here's a report showing that in those patients in which hearing was preserved, about 90% of those patients maintained good hearing over the long term. There are a handful of studies which call this into question, but it's generally agreed upon that it is durable. In summary of hearing preservation surgery, there's about a 3% recurrence risk, probably 95% House-Brackman 1 or 2 facial nerve outcome, and serviceable hearing at about 50%. There are a number of comparative studies, all with a set of flaws. Here's one in which hearing preservation surgery was rarely attempted, which demonstrated a improved outcome both in hearing and facial nerve function for radiosurgery compared to surgery. Again, a similar study in which hearing preservation surgery was rarely pursued, in which improved hearing outcomes were demonstrated in radiosurgery in regards to both hearing and facial nerve function. If you look at quality of life between radiosurgery, observation, and microsurgery, in most domains, at 7 years post-treatment, the study showed little difference. It did show an advantage to radiosurgery and observation for PANQOL scores. Actually, a study I like a lot was basically it was a matched cohort study between Golfinos, who's a very good microsurgeon, and Kanzioka, who's a very good radiosurgeon, both at the same institution, in which they took matched tumors in size and hearing status, and compared their outcomes between radiosurgery and surgery. They had advantage in radiosurgery and facial nerve function. There was an advantage of radiosurgery at 3 years for serviceable hearing. The study makes the important point that 43% of patients had preserved hearing in the microsurgery group, while 85% had it in serviceable hearing. And this is 3-year data. And so we would expect that if we look at 10-year data, that probably those numbers will at least match, if not cross over. Both treatment groups had 2 patients in which required subsequent interventions. If we compare conservative management to radiosurgery, the results are very similar in quality of life and hearing outcomes over a 5-year period. So a couple caveats to those studies. The surgical benefit occurs in the long term, while the risk occurs up front. And I think that's the primary one. And so if I break these down into kind of a simplified chart, if we look at each of these strategies and each of the considerations, we get something like this, which demonstrates some areas of benefit for each of the modalities and some risk for each of those modalities. When I look at this, I don't know if you're familiar, but there's something called the prisoner's dilemma. This is from a discipline in economics called game theory. You know, the question is that there's a number of strategies that one may take, and those strategies have both consequences and benefits, and depends on events along the course into which one's optimal. When I think of vestibular schwannoma decision making, I see this classic economic game theory Punnett square, where if we consider that there is a benefit over time, let's say there's a value to hearing, and let's say that 1 year of hearing is worth $10. That over time, if you look at radiosurgery, that you will have a $90 value in that, because you will maintain good hearing for a period of time and that will drop off. If you think about surgery, you have about a 60% chance of preserving that hearing. And if you're going to survive 30 years, then that value at $10 a year of good hearing is about $180. Even if you lose your hearing, that's considering the 40% that's going to lose it. So there is some benefit to think about this, and I think we can become much more sophisticated in our vestibular schwannoma decision making by using some of these tools from other disciplines. So that's where we were and where we are. This is where we go. And this is from the 4th chapter in my father's operative atlas of meningiomas. You can imagine the burden of finding such a quote in your father's book, that we are intended to surpass them. So I think that we have a lot of advancements, a lot of opportunity for advancement in vestibular schwannomas. I think in the first category of that is disease understanding. First, I want to introduce an interesting idea that that some of these tumors grow and don't grow, and that there's potentially an inflammatory reason for that, and there's an argument for treatment of anti-inflammatories. There's an argument for identification through imaging of through advanced imaging, which tumors will and won't grow. I think, secondly, understanding the disease is we've spent 120 years on vestibular schwannomas talking about extensive resection, facial nerve outcomes, and hearing outcomes. And we've neglected a symptom that really can have the most impact on our patient's life, which is vestibular disability. We have a poor understanding of the vestibular disability in these patients. We have a poor understanding of what its response is to treatment. The data is both scarce and very dirty. And so I think improved reporting on the outcomes of vestibular symptoms is necessary. There's some interesting work from Dr. Stankovic about inflammatory molecules which are secreted from vestibular schwannomas, which are the source of hearing loss. And they present the idea that by blocking these molecules, that you can lower the likelihood of hearing loss in conservatively managed tumors. So tumor necrosis factor alpha is one of the primary substances secreted from the tumor. Idea being that if you blockade this, that those conservatively managed tumors may be less likely to lose their hearing over time. And so I think this is an important avenue to explore in the future. Hearing restoration from our ENT colleagues is a rapidly expanding and very impressive field. The FDA recently improved cochlear implants for even single-sided deafness due to its effectiveness and improvement in patients' quality of life. And the implants are improving with spatial recognition. And I think this is going to be a remarkable thing that we see in the next 30 years. So this was actually an idea presented by my father of the concept of preserving the cochlear nerve, even without preservation of hearing function, that with the technology that's on the horizon, preservation of the cochlear nerve may likely could be useful for restoration of hearing with advancements in cochlear implants. I think radiation technology still is going to see some improvement. Hearing preservation in vestibular schwannomas is certainly associated with cochlear dose. And in this particular study, they demonstrated that patients that received less than 2 gray did not experience serviceable hearing loss. So as these machines continue to improve, hearing preservation with radiosurgery will likely improve as well. Imaging is improving, and even identification of the facial nerve through DTI. We can all imagine just how useful this would be to us in our preoperative planning. And I think the area of most growth ahead of us in the next 30 years during the course of my career is going to be surgical technique. I put this slide up here to say a couple things. One, this is a picture of from Yazergil's microneurosurgery book of the tools that he uses for removal of a vestibular schwannoma. Here we are 60 years later, and this is a picture from my vestibular schwannoma surgery, in which I'm using the same tools, the same optics, and frankly, I'm hoping to achieve the same results. You know, I'm happy if I achieve the result that Bill House achieved in 1964, and that's preservation of function and total resection. We haven't advanced beyond this, except in consistency of our results. And I think there are a number of ways in which we can improve with tools that are just reaching maturity right now and will be with us soon. So the manners in which we're going to improve is through improving our visualization, improving our dexterity, improving our haptics, and restoring function, not just preserving function. We're beginning to see augmented reality entering the field. You can imagine this would be a useful surgical adjuvant if you could augment the location of the facial nerve from your DTI imaging into your surgical field. There's, with the advancements in camera technology, there's an idea coming along of panoramic visualization and laparoscopic surgery, with the idea that you're not just seeing your line of sight, you're seeing the whole room from multiple angles. And so if you imagine microscopic cameras in which you may enter into the surgical field, you can see the tumor not just from the side you're working from it, but from the other side where the facial nerve and cochlear nerve may be apparent, that corner in the CP angle that can be difficult to dissect from the brainstem. And then finally, robotics. Robotics has changed urologic surgery. It's changing general surgery. It hasn't touched microsurgery, but that is coming to us and coming to us very soon. The reality is that no matter how good of a microsurgeon you are, you have some degree of tremor, and you have some limit on the scale of your movements. It's mechanical, and certainly we can build a machine which has a mechanical advantage over our own hands. This is called the Musa robot. There's a couple other microsurgical robots on the horizon. It's been utilized for microvascular anastomosis already. It has the capability to reduce tremor and has capability to scale down movements. And so, you know, we can be better microsurgeons than even the most skilled microsurgeons before us with the use of such technology like this. And so when I think of acoustic neuroma surgery towards the end of my career, with the tools that are beginning to reach maturity now. This is even in the absence of a major disruptor of a technology that would advance us beyond this. But you know, maybe I'm using some type of camera, optic, virtual, augmented reality to visualize my field that includes tensor imaging of the facial nerve, that gives me a panoramic view of the field, that reduces my tremor and improves my movement in a resolution that's even beyond the microscopic capabilities, that we can have camera technology beyond that, and that will improve to three-dimensional. And then I think most importantly, that improvement, that our surgeries are not just preservative, but restorative, and that as these hearing technologies advance, that they're utilized to restore lost function in our patient. And you can imagine the vestibular function system could be used similarly. So I think that's my time, and thank you everybody again for allowing me the time. I'll turn it back to Professor Borba.
Thank you. I can connect my phone here. Yeah. Okay. Hello? May I ask everybody to, it is still here, turn on the camera? I see a lot of people in the panelists, a lot of experienced surgeons in the panelists. Dr. Al-Mefty, Professor Armando Basso, Professor Benedito Colli, Claudio Vidal, all the people around this area, Dr. Enrique Osorio. Dr. Basso, are you here? Professor Basso? Can you turn on your camera, Dr. Al-Mefty? Yeah. Professor Basso, first of all, thank you very, very much to be with us. When I was listening to the presentation of Dr. Kate, came to me one question. In Argentina, we had one of the first gamma knife, I think in the world, one of the first one. In Latin America was the first one. Yeah? And was the first in Latin America, no? Professor Basso?
Yes, was the first in Latin America and was the second in the world, because the first, of course, was in Sweden.
Sweden.
Yes, yes.
What your experience? I know that you are a microsurgeon, but you work in the same city to have the second gamma knife in the world. What you're feeling these 34 years of treatment of acoustic neuromas? What it was the first gamma knife, and now what changed? Why is so controversy today to treat acoustic neuroma, in your opinion?
No, really, I start my microsurgery that I learned with Yashar Gil in the 60s, the end of the 60s. And of course, I never considered, even we have the second gamma knife at the end in the late 70s in Buenos Aires. So, but I never considered a gamma knife as a good treatment for acoustic. But with the experience of some of our colleagues here in Buenos Aires, in some special cases with the small tumors, intracanalicular tumors, etc., we can, in specific cases, we can consider good hands. That is a problem that I discussed a long time with my dear colleagues, Dr. Julio Antico here in Buenos Aires, who has an enormous experience in radiosurgery. But in general, in the majority of cases, of course, I don't consider gamma knife as a treatment for acoustic. This is a problem because I spent many years in France. Unfortunately, in France, I don't know if some colleagues from France here in the audience, but in France is many cases that could be the solution is microsurgery, of course, and it's not very difficult to remove completely and preservation of facial nerve, and even in some cases acoustic, the cochlear nerve. The majority of cases are treated by gamma knife. I completely disagree with this policy.
I don't know if somebody want to say something. Dr. Guinto, Professor Guinto? I know yes. you have a lot of experience in acoustic neuroma.
Thank you, Professor Borba. Congratulations, Dr. Kate Al-Mefty, an excellent presentations. It's amazing. I want to ask you some question. This is a typical question in nowadays microsurgical treatment of vestibular schwannomas. Is the planned hybrid surgery? What do you think about that? I think, I mean, planning a portion, mostly of course in large and giant vestibular schwannomas, planning a partial removal and observe the residual tumor, and if the residual tumor grows, send it to the gamma knife, just in terms to protect the facial nerve. What's your opinion about that?
Well, I was I think the idea to go anywhere and plan to do an incomplete work does not resonate with me. I have, particularly in my giant acoustic neuromas, plenty of residual tumor floating around out there. But I went there with all the intention in the world to remove that tumor and patience and diligence, and sat there as long as it took. There are a number of studies that demonstrate that strategy is no safer. This strategy of going there, coring out the middle and running is not a safer strategy. And I believe it. If you do it, you're not understanding the anatomy, and it's dangerous. Now, if you go there and dissect the tumor, dissect the facial nerve, and the tumor is adherent to the facial nerve, I think it's the right thing to leave a very small residual, and this very small residual will rarely grow. And if it does, you have plenty of options for it. So, I think preserving the facial nerve in modern acoustic neuroma surgery is essentially mandatory, even for giant tumors. But to go there on purpose to leave tumor behind, it doesn't suit my mind.
Okay, thank you. But my question was because sometimes I'm sure you have seen these patients. You do your surgery, very fine surgery, and dissect very clear the facial nerve, and you expect that the patient is not going to have any important facial process. But sometimes you cannot get this, even though if you see a very good facial nerve preserved and a good response in the monitoring, intraoperative monitoring, and the patient has a very important facial paralysis. In those particular cases, in large, I mean in giant tumors, don't you think it's better to try to remove, as you say, but as the minimum doubt you have, you can leave a piece of tumor, not a very small, just to avoid this extreme mobilization of the nerve?
Yeah, I agree. I mean, I do not hesitate to leave a small residual tumor on an adherent facial nerve. But I think there's a danger in the mindset. And I think technically there's a danger that, if you coring out these tumors, there are numerous studies that demonstrated it doesn't have improved functional outcomes. So I think the way you describe it, I agree wholeheartedly.
Okay.
But I think the way that it's promoted elsewhere is a poor mindset.
Thank you. Thank you very much, Professor Al-Mefty. Thank you.
Dr. Al-Mefty, today, where are you?
Oh, I'm here. I'm listening.
Okay.
How can I leave Borba?
Okay, let's make a question for you. You have a 2 centimeters tumor, okay? A small tumor. Good hearing, okay? Facial perfect. Young lady, like Brazilian, you see? Beautiful. Beautiful face. How you convince her to do surgery if the guy from the other corner is saying that she'll go there, do just one shot, and the tumor kill? And in the follow-up MRI, do you see the tumor radiosurgery shrink? How you convince this lady? Please. Go ahead.
Borba, first, that's exactly why I'm sitting down with every symposium you have made, because I learned. And thank you, the Latin American Society, Planck, and every person has contributed to those series, and certainly Sao Paulo Society. And I learned, and your question is perfect question to learn, which I would love to hear the answer from Kay, because to tell you the truth, and I'm not playing the devil advocate here, I'm being the devil himself. Thank you, Kay, for putting it together so well. Thank you for putting it together without really biases. But the answer to your question, Borba, from me, is what Keith has said at the very end of his presentation. We, the surgeon, gotta do better.
Põe a Coca-Cola para tua avó, depois você acaba de jantar.
We, the surgeon, have to do better. And we are lucky today that we have all of this advancement and technology and super things that we shouldn't hesitate a moment of adapting to do better. Now, I didn't have that problem of the question you asked me. I had a very young, beautiful lady, and very kind and generous, but they were trusting. It's how you capture the trust of the patient, that they believe you want to treat them for a good reason. Whatever you're going to do is for them. And luckily in my situation, they all were larger tumors. I have very few smaller tumors that you could even consider for gamma knife. But if you have a very clear, noble intent in the management of the patient, small one, is the hearing important for you? Do you want to preserve the hearing? Then I will operate. Large one, you're about to have a brainstem compression and hydrocephalus and threaten your life, I would operate. A medial sized one, you're a young person, it's growing, it's gonna get you. Now it's the best time to take care of it. If that patient understood, patient take the risk. You know, Angelina Jolie, the greatest actress, had an operation, bilateral mastoidectomy, because she had the gene that she may develop cancer. She didn't even have the cancer. If a patient knows what it is you're treating, what's the goal of the treatment, and that's the goal they want to achieve, they accept risk. Now, but if next door tell them, hey, listen, you don't have any risk, you're gonna smile tomorrow, you're gonna be fine, we're gonna treat you 98% cured. They don't tell them control. 70% hearing preservation. They don't tell them that in the first 2 years. Some patients, they believe and they're not going to come to you. And if you tell them any different, then they're not convinced. With all of the beautiful presentation Case did, and with the thousands and thousands of cases being treated with radiation for vestibular schwannoma, I, deep in my heart, don't think anybody in a benign small tumor should be exposed to radiation that we don't even know if it works. If two-thirds are already, 70% are already in good control. So what you're adding to? Gamma knife is yet to prove that these does anything effectively, except the risk of radiation later. When they were treating with 14th gray, they said the tumor shrink in 25%, I think, and the control is 98%. But the facial nerve weakness was 4 or 5%, and the hearing was so and so. So they kept dropping the doses. And now it's a 12, no? Case put 13, but I think in some places a 12. Correct me, anybody.
12.5. 12.5.
12.5. My question is the 12.5 the one we will give the results for the good facial function have any control on the tumor? You see, when you get the control rate, you get it when they were giving 16 gray. When you get the facial nerve weakness, you get it when they're getting 12.5 gray. But this is a personal bias, not personal bias. I mean, there is enough to understand this and believe. But the case has presented it in a very neutral, scholarly way, and here the number in your face. So yes, I had no trouble with a good, nice, beautiful, young lady. They were not from Brazil. There is a beautiful everywhere. And they, if they know why you're treating them for, what your goal of the treatment, and they know that you do care about them, they will accept the risk as soon as you, for a good reason, you capture their trust. Not
Doctor,
them, but really serve them.
Okay, Dr. Al-Mefty, Kate just showed that the conservative treatment of patient on acoustic neuroma, almost 30% doesn't grow, 90 to 10% decrease. Maybe the conservative treatment is not the best way to treat some acoustic neuromas that we are sending to radiation or doing surgery. I know Dr. Ribas has a lot of cases, meningioma and some acoustic also. He treat conservative, and he was always talk about incidental meningiomas, incidental acoustic, in pituitary they call incidentaloma. See, maybe the conservative treatment is not the option. One more player in this game. Dr. Guilherme Ribas, please, go ahead. turn on your microphone.
Okay. Are you hearing me? Okay,
yes,
well,
yes.
Thank you very much for this opportunity, and congratulations to Al-Mefty Jr. and to Al-Mefty Sr. It's a great pleasure to see you both together. Yes, I'm very interested in incidental findings. It's something we see more and more. And regarding conservative treatment, I think that it makes sense, as Kate showed, particularly in small tumors and asymptomatic incidental. And at least for the patient to absorb, to understand what he has. And the other thing is that we have to be humble that it's not everywhere that we have a very good surgeons for a CP angle tumor, as you might have in America, if we're talking about worldwide. So we really have to study and to understand the conservative treatment. Now, I have a question to Kate. You showed, for example, you said that conservative treatment and radiation treatment had a similar result. A question I always ask myself, how can radiation treatment data show that the tumor was stable, since the natural history can still leave this tumor stable? How can it mathematically be done? How can it statistically be done and be written in a paper that you had a percentage of stable because you did a certain treatment? Can you answer? Maybe I'm wrong. Maybe statistically, if you have big numbers, you can prove that it became stable. But since the natural history can give us this, how can this data of radiation treatment be understood? So no doubts about what Dr. Al-Mefty said about conservative treatment better than radiation. And radiation, it's not something to start with. I agree completely. And thanks for the opportunity. But please tell me if how can they say that radiation treatment can leave something stable, since the natural history can have the same result?
So there is a paper from Ghazi that addresses that question. And essentially takes a mathematical equation of if you treat 100 tumors and you assume that 60 of them weren't going to grow, and they were all treated with gamma knife, what percentage of tumors were going to grow and didn't grow because they got radiation? And they determined that answer is as 78% as of tumors that would have grown but didn't because they got radiation. Using just math and numbers in the literature.
You think this is really trustable?
No, I think it's manufactured, but it's a statement to your point. Who knows about 20 years out, but certainly at 10 years out, there are fewer tumors that grow after radiation than there are tumors that grow on their own.
Yeah, but Keith, we've been hearing this 30 years ago. This number is actuarial. And since I don't know English, I thought actuarial all of this year mean actual. So when they said 80% control, I thought those people really, they have 100 people, they live 10 years, and 80% of them got control. Well, I learned later better English, and I knew that actuarial is just a guess that the virtuary of the insurance company, the actuary of the insurance company put on your head. We're still there. Are we right? All of those numbers you're giving me, 8 and 90%, is actuarial. that mean
Yeah, they're all Kaplan-Meier.
the Kaplan-Meier thing, which doesn't mean anything.
I wouldn't say it doesn't mean anything. We use it for everything.
You use it for everything, but and this is deceiving. When you tell me 90% 10 years, none of those patients, one of those patients got to the 10 years. And the rest got plotted on that Kaplan-Meier curve. I had that problem now for a long time to claim the actuarial control and make me and the patient believe that this is the actual control.
Yeah, I mean, I think that's why the median follow-up of the studies is important.
Absolutely. And those studies, yet after 30 years, they still, the best of them had 60 months and 70 months.
Yeah. And you know, I might be wrong, is there should be 20-year papers now, and I haven't seen them. You know, what comes out now is the 10-year data at 12.5 gray, not what the 20-year data was for the 14 gray. To your point.
Can I ask one more question, Professor Borba? To anyone help me?
Go ahead. Go ahead.
I had all of those doubts, and I cannot understand sometimes what they're talking about. In meningioma, for sure, the numbers is out. If meningioma is growing, the radiation effect on it is very little. Okay.
Oh, it was my question. Go ahead. Go ahead.
That's one. And two, in all meningiomas, the effect of radiosurgery decline year after year after year after year. That around 10 years time, that all the numbers are dropping below 50 and down to the 40%. Those numbers are out. We're seeing them from the people who's honestly reporting on the Gamma Knife experience. Why this same phenomena are not being reported or seen in the schwannomas?
Let's ask Linda B. Linda, what's happened? Meningioma irradiate, explode. Schwannoma irradiate.
I would
the
love
great majority, nothing's happening. Don't cure, but don't change. Why?
I would love to know. You know, I'm curious about the following though, which Dr. Al-Mefty may have pointed out before, I think in a study with maybe Keith or Paulo. Those meningiomas that explode after radiation, even if they were benign meningiomas in the inception, seems perhaps that they had something wrong with them, even if it's just one thing, whether it's a chromosome 22 loss or 1p loss, or they may have been masked as a benign tumor, but they had something wrong that then became the basis for becoming more messed up. But schwannomas have nothing wrong, you know, with them in the majority of cases. And so, you know, I wonder, because there are cases of meningiomas that 20 years later, you see the patient after radiation and they have not grown back. I wonder if the truly, truly benign meningioma with nothing wrong can do better than the ones that were semi-benign and had but a little bit something wrong. And would schwannomas then be more like that? I see Paulo has an answer.
But That's doable. But the benign meningioma, the natural history will be very similar with the radiation, no?
Well, that's what I don't know, because a third of what we call a benign meningioma may not be truly benign, meaning that they may have something wrong with them in terms of whether it's a genomic alteration or whatnot, and we consider them grade 1 meningiomas. So if among all the tumors that we radiate in meningiomas, those that have the so-called long-term durable control are truly, truly innocent, benign, with not a single thing going on. So they would have done well with or without radiation, with or without surgery, with or without, whatever. Is it the other population of benign meningiomas that were just leading down the path to sinning? And are schwannomas just more innocent than that?
Paulo, go ahead.
Yes, I do have a question, like exactly the point that Linda B did. We have been seeing more and more regarding of the doses, treatment of trigeminal neuralgia with gamma knife. Have everyone seen more trigeminal neurinomas because of that?
After radiation, said?
Yeah.
No, never seen it. Never hear about that. Somebody hear about that?
Did you, Professor?
Professor Basso?
No, I never see something like that.
I don't know if this is because of the doses, but it's radiation. But we don't see trigeminal neurinomas after treatment of trigeminal neurology with gamma knife.
The other
Doctor,
sorry.
Go ahead, please.
The other thing that we very rarely see is a radiation-induced schwannoma, right? Like there's probably 10 cases of cervical radiation-induced schwannomas, but thousands of times of that of radiation-induced meningiomas in the same patients who had.
Problem, the Schwann cells are more resistant to radiation.
So there's something different there.
For good or for bad?
I do believe it's for bad because it's better to do the neurovascular decompression, right?
No, during many years, a lot of places in the world, I think in Brazil, before radio surgery to be developed in Brazil, a lot of patients with posterior fossa, or schwannomas also, acoustic neuroma, large acoustic neuroma, was treated with radiation, conventional radiation therapy with high doses. There is a clinic in Campinas that Dr. Montemor works doing work in the past. They had a lot of experience on this. Do you remember? Have you ever seen this transformation from malignant, from acoustic neuroma? With different kind of radiation therapy, not radiosurgery.
We have a young girl that have performed radiotherapy, 5,000 centigrades in another city, and before 7 years after the radiation, the tumor was growing. We performed a surgery, and 3 months later, the tumor was twice done the first surgery, and it was a schwannoma malignant schwannomas, and this young girl get the surgery, but it don't live more than 6 months. The tumor invaded the brainstem, the mesencephalon, and the anterior fossa before the surgery in 5 years. But it's not common. okay? But it's possible to before the red surgery. I was working during 3 years with a medical physical that she was said to me 20 years ago. You're a doctor. Don't forget, radiation kills tumors, but radiation kills people with health. And the surgery, the rad surgery and the rad therapy must perform with more and more good sense. I think that who becomes and indicates the treatment must be the neurosurgeon. The neurosurgeon that performed surgery and the rad surgery. I get some experience with the rad surgery during 25 years, but I'm a neurosurgery for 40 years. And I'd like that there is no good treatment for some cases. I have talked to my patients. When you have more than one treatment, not one is a good treatment, because if you have only one good treatment, there is no alternative treatment. There is no, in my opinion, we don't have treated protocols to the patients. We have performed the treatment patient one by one. Each person is a only person, but you don't take a single treatment for all the patients.
What you are seeing today, I think in the near future, is I call woodpecker surgery, the hybrid surgery. But not a real hybrid surgery. For me, the concept of hybrid surgery, you remove the maximum that you can, you save the structure, you leave some piece, a small piece. I observe, but some people resent to radiation. But we are seeing around the world today is a guy go there is a 4 centimeters tumor, just decompress a little bit in the middle. Sometimes either the biopsy is difficult for the pathology, it's difficult to find the tumor, and send to radiation. But not the real radiosurgery. They send to call fractionate stereotaxis radiosurgery. That is radiation therapy. No. Many sessions is radiation therapy. I think in the near future, we will start to see complication of this treatment. Because I think radiosurgery with 13 or 12 or 12.5 is like a soup in the hospital. You say here in Brazil, you have a soup. The soup in the hospital is okay for everything. There is no problem, nothing. Maybe this is the problem. I want to make one question to Kate and from Dr. Al-Mefty, from all the people. Now the people, this ablat, how say, you have the tumor, you do the mapping with the brain. I think a brain lab, the ablative, I don't remember the name, that where they found the facial nerve, they can find the facial nerve in the MRI in large tumor, and do the surgery and remove, guide by the brain lab navigation. This is real or this is fantasy? And the other thing, how easy to find the facial nerve in the MRI for large tumor. Sometimes it's very, very difficult to find in surgery. Imagine in the MRI. Dr. Al-Mefty, you are the man in the...
Yes, sir. And I want to hear what Keith knows about it too. The concept of you being able to see on the MRI where is the cranial nerves. It's a beautiful concept. Okay. Now, this segmentation and imaging and everything, we're big at it in here in a Brigham. And a big work is done by my good associate, Dr. Golby, into the brain tract and all of this. And I, a while back, carried to trying to segment the cranial nerves. Okay. I want to see where that facial, like you said, I want to see where the trigeminal, the six, what have you, especially in big tumors. And there is now a few radiological technique came out, special sequences that could enhance seeing those nerves. Now, having said all of that, it's nowhere near that you could navigate to them, because the navigation error, no matter what it is and how best it got, it's bigger than to take you right into the little displayed fascicle. So you cannot really write on your stick, and here it is, right to the facial nerve, like you would do stereotaxic biopsy in a frame. But it is a very good idea to know in advance where to expect those nerves. Ventrally, superiorly, split in two, push down. It will help you a lot, but will not replace the stimulation. The stimulation is so accurate that it's really your main guide into finding those nerves. Yes, the study should continue, the improvement should continue. Yes, there is a better technique now to try to segment those nerves into the wall of big tumor, but we are not there that you could zoom and navigate to them. Hopefully one day will come. It will be beautiful.
Borba, so
Microphone.
For a small tumor is okay, but for large tumor, if MRI, I think it would be very, very funny way. I don't know. I'm asking the panelists if somebody has the experience and what would be the result. You do the surgery, the neurophysiology, everything is okay, and the patient wake up facial palsy. What's happened? What was the problem? In hearing, you know that sometimes you preserve the hearing, the patient can lose the hearing in the follow-up. But the facial nerve, how often it's happened, Kate, in the literature, see? What is the correlation of the preservation of the function intra-op and post-op facial palsy? How is the result of this?
I don't know exact literature numbers, but I think the correlation is very good, very good. You know, if you stimulate less than 0.05 or less than 0.08, you're going to ultimately have a functioning facial nerve. And I haven't had that problem. Now, the delayed facial palsy, I've suffered that problem a number of times. But those all still have one out there, but I think those all get better.
No, the delay is
Can
okay.
I say on this thing one
The
thing?
delay is okay, but acute after surgery.
I don't think I've had that. Where I went to the brainstem, I stimulated, it was 0.05 and the person woke up with a bad facial palsy. I have not had that.
It doesn't matter if delay or as you describe it. If the facial nerve is truly intact, in continuity, it will recover. It's just a matter of time. The recover and delay facial paralysis is so high that it doesn't matter. Just the patient need to know that you could wake up smiling and a week later you will be paralyzed. Or I swear the nerve is intact and stimulate during the operation. Just let's wait till it get better on you.
I think
I agree
Dr.
I agree with Professor Al-Mefty. Yes, if the stimulation during surgery is positive and the facial nerve is preserved, if anatomically is preserved, and then you have a palsy, I agree with Professor Al-Mefty. You have to wait. You have to wait, and certainly the majority, it's very, very, very in rare cases, never recover. But in the majority, 90% of the cases, in time after 1 month, 2 months, even 6 and even 1 year, the facial nerve will recover little by little. That's my experience.
I have a question.
Just go ahead, Ali.
Okay.
Professor Chris is here. See, look at. Yeah.
Well,
he's getting old. You see, his hair is white now.
Yeah, I'm sorry. I had the time mixed up, so I guess I thought it was 6 o'clock our time, but it must have been earlier, the lecture. But I have a question about the last part of the operation when you got the tumor from the canal and from the brainstem, and then you're struggling with the transitional zone. And then this is when there are some cases where every time you try to remove that small pieces, the facial nerve starts telling you I'm angry. And every time you start to pull some, you with the stimulator kind of starting to go crazy with the irritation. So the question is, how far should we go, and is that small piece in the transitional zone, if we leave it, are we taking significant risk of recurrence? Because this is the part which, especially in very thin, flimsy nerve, that I start worrying. I have good stimulation from the brainstem, and now I'm going to mess it up with that last piece in that corner. Over time, you start going back and forth on it. And at least in the cases I have been leaving those small pieces, so far it hasn't been too bad, but I still question how far to go and how far to, when to stop. What's anybody's experience with that small pieces in the transitional zone when you're trying to fight those last pieces?
I think Dr. Osorio has some tricks to preserve the function of the facial nerve in they use some drugs. Tatajiba use, I think so, no? Go ahead. Turn on the microphone.
Yeah, thank you. Thank you, Dr. Borba. And I enjoyed the presentation of Professor Al-Mefty, Dr. Kate, and his father. But I have not trick for that. But I think that the one there is something that they help for me is to use some the irrigation of papaverine or nimodipine during the resection, during all the operation. And because many times the compromise of the nerves is because the spasm of the small arteries. And I think this is a good help for us in these operations.
Professor Borba.
Yes, sir.
Where
are you?
I'm right here.
Okay, good.
Can you just for me, we got shut off. Okay, a consensus starting with our with our speakers of the following questions. I'm a patient who has a small intracanicular schwannoma and still have a good hearing, and I do not want to lose that hearing. Will you operate me?
Who operates Dr. Al-Mefty? Paulo Cadre. Why?
Of course, it will depend on your clinical condition. But if you have a good clinical condition, I will do. I think that it's safe and feasible, and we can preserve the hearing.
Dr. Guinto.
Well, it's very difficult to answer that because unless in my hands, in that particular case of 2 centimeters, intracanalicular. Yeah, even a fine manipulation of the cochlear nerve, it generates some kind of hearing decreasing. So I would not operate on you, mostly if it's Dr. Al-Mefty.
No, in Dr. Al-Mefty is easy. Clinical condition, Dr. Al-Mefty.
I think it's not possible to say to the patient that 100% I preserved. It's not honest.
No, but it's not 100%. You're gonna put the numbers.
No, I don't
If
want
the guy say, I cannot lose the hearing, you cannot operate.
No, listen. I understand that I have 60% or 70% the chance to preserve my hearing if you operate on me. I know that tumor is not going to kill me. I know nothing is going to happen to me if you just observe me, but I want the chance to preserve that hearing, knowing that it is, what's the latest number for intracanicular fine microsurgical preservation?
But
Okay,
if you
what's the number?
If you accept it,
we lost our speaker.
If you accept it,
50% is a good number.
He's here.
I think it's
75%.
75%. Yeah.
50 to 75. Depends on your preoperative hearing, depends on your anatomy. My question is, are you asking us, do we perform hearing preservation acoustic surgery for the sake of hearing preservation? Or would we do this to you? You.
No. I'm asking. I'm a patient, not me. I'm a patient who's very concerned and wants the best chance to preserve his hearing, and who found that he have an intracanicular tumor, and went to see 100 neurosurgeons who will operate me. I do not want a radiation.
And you're 35 years old.
No, I'm 64 years old.
Hearing is one of the senses. Hearing is one of the senses, like vision.
More
If you
important.
have
The other side.
preserve it, you should.
Professor Basso.
Listen, the most difficult tumors for me trying to preserve the hearing is the intracanalicular tumor when you try to remove, because you never know the results. That means the only situation when I operate those patients is when they has lost the hearing. He completely lost the hearing. Okay, if he accepts, I operate even if it's a very small tumor. I prefer surgery and not radio surgery. But if they, I remember a patient one day with a small tumor. He told me, if I lost my hearing because he was a musician, I will commit suicide. So I said, okay, go to radio surgery, no problem for me, because this is very, 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 very difficult. One thing is important that I would like to remark here concerning radio surgery. One thing is the radio surgery, because in my country at least, many people call radio surgery some kind of radiotherapy in different situations with the LINAC system and so. The only real radio surgery in the market is a gamma knife radio surgery, because it's with more than 200 source of cobalt. This fixes radiation. Is the more accurate, in my opinion, if we are going to indicate that thing. The other so-called radiosurgery are not the real radiosurgery.
Question number 2.
No, wait, just one more.
What the answer?
If we can do a comparison, if you are losing vision, you wouldn't think twice to open the canal and take the tumor out.
But we would depend more on vision than hearing. You know, it's a most important sense that it does not. Well, if we compare, but we have to talk about useful hearing and hearing. To preserve useful hearing, even in those small tumors, intracanalicular tumors, is very difficult.
Gerardo, that's the whole point. We do not recognize, we do not realize how disabling hearing loss is. It's worse to lose the hearing than to lose the vision in one eye.
You think so?
More disabling. You cannot work, you cannot know, you cannot talk to your wife, you cannot buy anything, you cannot defend yourself, you cannot explain anything. Hearing loss is a tremendous disability. Look at me, I changed about the 4 hearing aid during this 1 hour.
In evolution, Professor, hearing comes before vision.
But for instance, we are an example. We can operate on a patient with just one ear. We cannot operate a patient with one eye. So it depends on the particular case of the patient. But if you give them to choose, I'm pretty sure that most of them are going to choose to lose hearing in one eye and one ear, and not to lose visual vision in one eye. It's very, very controversial, of course, but Paulo brought to the table that is very controversial.
Hey, Paulo, I will come to you and you take my my acoustic out.
You'll be deaf.
Alligators here that
you come back home deaf, completely deaf.
Question number 2. I am.
I'm sorry, I cannot.
38 years old, and I have 1.5 centimeter acoustic. will anybody send me to radiosurgery?
How old? Sorry.
35.
Oh, no.
Unless you have some clinical disability that you cannot go to surgery.
But everybody told me I'm gonna be paralyzed, I'm gonna be disfigured, I'm gonna be Frankenstein, I'm gonna leak CSF, I'm gonna have meningitis. If anybody do an operation on me, while you could give me one morning and I go home in the afternoon, and I guarantee you that I will be fine.
I think those people who told
To tell the truth, it might happen. It might happen, but it's not common.
I think those people who told you you're going to be paralyzed and all this stuff, they are right. You shouldn't have the surgery in their hands.
Yeah, but they are just about 80% of the surgeon out there who's giving the gamma knife to me.
Yeah, go to the 20%.
How will I know as a patient?
Yeah, it's a good question. You're right. Unfortunately, I think most patients, if they do the right research, they'll find out. But some of them may not get the exposure. You're right, and that's a problem. That's a problem.
Our expert speaker, how many radiosurgery a year right now? 50,000 around the world radiosurgery for acoustic?
Yeah, I don't know the number, but far more tumors are treated with radiosurgery.
How many of those are of, let's say, less than 50 or younger age?
Yep.
Big number.
Huge number.
Question number 3.
I think there is no hesitation in the neurosurgical, at least in the U.S. neurosurgical community, to give radiosurgery to any acoustic, regardless of age. The only exception being neurofibromatosis 2.
Yeah. So we've got a problem with the acoustic, is the whole understanding of the disease.
We say that, but I haven't done that many failed tumors.
Well, that was my first question. Why we are not seeing them?
Where are they?
10 years down the line.
If you're arguing those numbers aren't real, they're actuarial numbers, where are they? They've been doing this to hundreds of thousands of people for 30 years. If it's truly not effective, then they should be in my clinic.
That's the funny thing. They present 200 cases, 300 cases, and not more than that. They do to 100,000 of people. They present with a follow-up of 2 years.
But it's spread out. It's not like microsurgery that you go to Professor Sammy and get your acoustic out at this one place. Right now, I could drive in 1 mile to 4 different machines, and each one of them are treating acoustics.
Now, you know what the radiation tolerance of the optic nerve?
8 gray, right?
8 to 10 gray, depends on the volume. You know that the motor nerves radiation tolerance is much higher than the sensory nerves. So what the 12 nerve, or what the 12 gray doing for anything to anybody? If you're saying I'll give it to normal tissue and would not hurt it, why you're expecting it to stop the tumor from growth?
Probably they'll give meningioma.
No, no, I'm serious. Question number 3. Those are the issue which bothering me. Is it okay, Borba, to bring them up?
Well, go ahead, go ahead.
You go ahead. Question number 3. I am a patient. I went to the doctor and told him, I do not want to have facial paralysis. So he told me, don't worry. We will go and do conservative decompression. We will not attempt to remove your tumor, so you will not have the risk of facial paralysis. Would you, doctor, please do for me? I trust you, I want you, but do what he told me. That's for you, Borba.
I was not listening. I talk to the machine. Can you repeat, please? I had my. Can you repeat the question? I was listening.
I have a tumor.
Yes.
Acoustic.
Yes.
I came to you.
Yes.
I told you I do not want to have facial paralysis whatsoever.
Okay.
I trust you.
Okay.
I want you to do my operation.
Okay.
But that other doctor told me, don't worry, you will not have facial paralysis. We will go and just remove partially the tumor. And you will not have a facial paralysis.
I think you cannot do this kind of promise to the patient. You try your best to save the facial nerve. If it's possible to remove everything, you remove. Not possible, don't remove. But I cannot say, I never say to the patient 100% to preserve the facial nerve. I never say 100% to preserve the hearing. See, sometimes you can, sometimes you cannot.
No, not what you say to the patient. What the patient saying to you. Do not remove all my tumor. Do not attempt to remove all my tumor. Because if you attempted to remove my tumor, I might have facial nerve. The patient requesting you not to remove all the tumor.
I think it's an option of the patient. But you cannot promise to him also, if you do a decompression, a real decompression, not bite a little bit, if the patient not wake up with facial palsy. See? I think it's an option of the patient. If
you will do what the patient asking you.
I will do, but I will never say to him, you not have facial palsy if I do this. I never say. Sometimes happen.
I see Antonio.
I'm living in a real world. The real world, complications happen. In the real world, the patient can have facial palsy. See?
Understand.
Independent of the size.
She is not asking you. She is not asking you 100% guarantee. She's asking you 100% not to attempt to remove all of her tumor.
I think I'll do it.
I think as long as you can preserve anatomically the chances to have permanent facial palsy are very low.
No, I don't.
To
Paulo, 1 second. I think the message you should give to the neurosurgeons, because did the radio surgeons say that you are wrong? You cannot say, I will remove everything, I will preserve the facial nerve, I will preserve the hearing, I will preserve everything. This message cannot be given. The message you should give, you do the best for him. I believe that in this size, you should try to remove the maximum. If I cannot, I cannot. This is the problem that some's happening, because the people from Gamma Knife is growing so fast. Because some people say that everything is impossible, yet other people say that in my hands I can do everything, there is no problem. This balance you should have. See, we have a lot of neurosurgeons around the world, in Brazil a lot, in Latin America a lot, in the whole. In my hands, you are safe. In the other hands, you are not safe. I think not this way. I think it's not this way. Because this, you have alternative treatments that are not good, but sometimes if the people want to hear it. Trust the patient. Talk with the patient. See? If he trusts you, he will do what you believe is better to him. If he doesn't trust you, don't do the treatment. I do this way. If the patient comes to me, I do what I believe is better. But if he say, I want to leave, maybe it's okay. Maybe it's okay. The problem, you are losing the relation between patients and doctors. Sometimes the lawyer is driving our treatment. In US, a lot. US, a lot. Nobody want to do more skull base. Nobody want to do bite a little bit and go home in the other day. Not better for the patient, it's better for the doctors. And maybe for the hospital, if not sue it. See? Our idea is to tell the best for the patient, but the final decision is from the patient, not our decision. I think it's his decision. He's the patient. I talk too much. I think, Dr. Colley is here. Oh, Dr. Colley. I believe, and more you understand the natural history of acoustic neuroma, less surgery you do, less radio surgery you do, more you understand the natural history of many. Today, there is a big issue in Brazil, I think around the world. We do a MRI, angio MRI, they are doing angio MRI to everybody now. Somebody has headache, angio MRI. And show 2 millimeters aneurysm. Many times inside the cavernous sinus. What's the popular treatment today in Brazil? Stent. Stent. Very small thing. We are understanding the natural history of some disease. I think the medicine is going from different way. The idea Dr. Al-Mefty always gave us to bring to this seminar is try to tell the truth for the patient and for the doctor. See? I don't know. The world is completely crazy. The world is completely crazy today.
Borba?
Yes, Dr. Colley. Oh, here. Turn on your camera.
Yes. No, my camera is not working.
Oh, you
I
didn't
think
fix
that
it.
the focus of the question of Dr. Al-Mefty is not what are you discussing. The focus is what to do if you do what the patient wants, not what you believe is the best. This is the focus.
Yes, I think so. This was the focus. Somebody want to say?
Borba,
Yes, sir.
there will always be this one possibility where you would go in and do partial resection, and the manipulation is enough to cause a facial weakness.
Yeah.
And then how are we going to answer the patient? Because that can happen. We cannot guarantee, because we don't know what's the results of partial resection, which could be as injurious inflammatory wise, like complete resection. So we are being asked to go into an unknown, pushed by the patient, and I think it is not good.
Yes. You cannot promise to him you're safe, independent of small removal or total removal. Cannot promise.
Yeah.
Yeah. I think this is my point. This is the point. I think you cannot promise 100% in anything in medicine. In neurosurgery is work. Go ahead, Dr. Al-Mefty. You.
Oh, I'm here. I'm listening. I'm learning.
Dr. Ginto.
You're asking for better Al-Mefty. That's
Dr. Ginto.
His microphone is off.
Well, particularly in the issue that Ali is talking, I totally agree that the facial nerve is something that you have to preserve, even if you have to leave the tumor in the transitional zone. I don't have any doubt in my mind. So, and you can follow the patient, and if the tumor grows, you can send it to radio surgery, or even reoperate the patient again, and maybe 10 years later. And facial nerve preservation is something that is statistic is very, I think is not very clear, because if you see the numbers, some people say that they can preserve the facial nerve in maybe 90 or 95%, but a House Bragman grade 3 or grade 4 is socially not accepted for the patient. So you have to pursue, you have to try to get a House Bragman paresis 1 or maybe one. It's difficult, 1, maybe 2 or maximum 3, because in this matter, the patient cannot be affected in the quality of life. So the main goal of the schwannoma surgery is try not to affect this quality of life. And if if you have to leave a piece of tumor in the transitional zone, I don't have any doubt in my mind that this is a good option.
I don't know if somebody wanna say something. You'll be forever here discuss about facial nerve hearing. You're not in the hearing, you're still in the facial nerve. But I believe that the facial nerve is still an issue in acoustic neuroma in the whole world, maybe for small tumors, but the tumor that we see in undeveloped countries, the great majority of times a large tumor in the facial nerve is still an issue. You should try to do our best, independent of that. I don't know, Dr. Al-Mefty, want to say something before you finish it? We are 2 hours talking here. Please go ahead, sir.
We're talking or you're talking?
You talk, you talk.
No, Borba, again, thank you so much for putting these things, because it's really, for me, it's a learning experience. And thank you personally, and thanks to all our Brazilian neurosurgeon who attended and participated and contributed, and all the Latin American neurosurgeon and everybody else online with us from any corner of this world. And they, I can't help it. I think we learned a lot from Keith. I think this is the type of presentation I'm hoping to look forward and learn from. So the last question in this issue, does it appear that the schwannoma submit, or let's say radiosurgery, not radiation, radiosurgery irradiation affect the schwannomas? That's what you all saying? In other words, radiosurgery or whatever the criteria, selective cases, whatever it is, it's a viable option in the treatment of schwannoma?
Kate, it's your word, your last word.
This is the real devil advocate question. you thought I'm gonna let you go.
Look, my heart is with microsurgery for vestibular schwannomas, but there are now repeated numerous studies that have demonstrated that radiosurgery is a tool for this disease, and certainly has a role, and has to have, the patient has to be included in that discussion.
Which patient will be then the ideal patient for radiosurgery?
Ideal patient for radiosurgery, no hearing, growing tumor, 1.8 centimeters in size, in somebody on Plavix that's 75 years old, 68 years old.
Is ideal patient for
operate on that
conservative
person,
also.
There's a machine that can avoid surgery and prevent that tumor from growing with 90% likelihood over 10 years?
You know,
maybe this is ideal.
I want to live to 10 years.
Maybe, Professor, maybe this ideal patient for conservative treatment.
Tumor's growing.
And the 1.5 centimeter
growing.
already in the CPA.
It's growing, 68 growing. In Plavix has heart disease. He'll die from the heart, not from the schwannoma, my friend. What do you believe, Dr. Basso?
I agree with you.
More you learn about conservative management of acoustic neuroma, less treatment you do.
But then we have to pay the machine. We put money in the machine, we have to pay the machine.
Okay.
Okay, thank you.
Okay, thank you. Now
Professor
it's
Borba.
10 p.m. Kate.
Thank you.
I have more doubt now. I don't know if I do surgery, radio surgery, or don't do anything. I think I go to the beach. Thank you. Thank you. Bye-bye.
Thank you, everyone.
Thank you.
In 2 weeks, will be cervical spinal stenosis, myelopathy. You go from the acoustic to the neck with Dr. Edward Benzel. Okay?
Okay.
Somebody has to study. I have no idea about this topic.
Thank you. Bye.
Thank you.
Thank you.
Bye.
Bye.
Thank
Thank
you.
you.
Ciao, ciao.
Bye-bye.
Thank you.